NGS in Nigeria, I think, is still an evolving area.
NGS has come to stay, but now targeted, there is recommended ASCO targeted markers. Even in breast too, I have sent samples of patients triple negative that are not responding very well to the conventional chemotherapy. 2 of them came out as BRCA1 positive, and they were placed on the appropriate drug. The response was so dramatic, and so it's actually changing the face of oncology practice in Nigeria, and the access is the most important thing.
What we are trying to do currently is to make sure we coordinate all the affairs, everything related to cancer in the country. And with this, different people have been doing different things from different centers, from different places. There are so many collaborations all over. But the NACRAT is like to collaborate with everybody to coordinate this. And if we do this, we are sure that this has come to stay.
I have practiced my clinical oncology practice more in what you would call a rural setting compared to Abuja. As essential as it is, as important as it is, with over a decade of trastuzumab dancing on the scene, we are having populations that do not even have the slightest of ideas, but we are moving forward. And so somehow something needs to be done to make these things go round. Otherwise, there's going to be that treatment for the rich and that treatment for the others.
At NACRAT level, we have to put everything in place, and which we are doing currently. We want to make sure that whatever clinical trial we want to do in the country, there should be rules and regulations that guide what we want to do.
And apart from that, carrying our sample out, that is where exploitation will come in. And we are happy that we can now have a place like here and Redeemer where you don't need to take your liquid biopsy or FFPA out. They will do anything they like with it. But now that we have a domicile in Nigeria, it's going to curb all this fear about exploitation.
The community health officers want to take family physicians so that as soon as they see, they should refer to the nearest center.
Literally make it compulsory for the patient who walks into the hospital to get the doctor asking, because he is of a certain age and or she's of a certain. Have you done a breast cancer screening? Have you done a prostate cancer screening?
The age of occurrence is becoming lower and lower and lower. We are now diagnosing many of the cancers I'm diagnosing in our lab now. Young women in their 20s, 30s, and even in their teens.
It should be domesticated as part of the normal process until we begin to catch prostate cancers and cervical cancers and breast cancers from individuals that walk into hospitals just to treat malaria or typhoid or for antenatal clinic. If we do not begin to catch these diseases at that stage, we are still going to be a long way off.
The issue of breast and cervical cancer, or in fact cancers in general, for us it is not about the policies but implementation, because the policies are actually there. Even as a continent, I think a few years ago, whether it was President Biden or whoever, was able to convince members of the all African countries who are members of the AU to commit 1% of their annual budget to cancer treatment and control. Fortunately for CA cervix, we now have a vaccine. So at least if we can do a lot of awareness and sensitization and ensure that our young girls become vaccinated with the human papillomavirus vaccine, which is available, and I think it's even free. So probably even if we don't protect our own generation, at least the coming generations will be protected from cancer of the cervix.